Hello, class. This is the last lecture of the year. We're going to be talking about doing psychopharmacology with children and adolescents. This is a very important section because rather than talking about a particular class of disorders or a particular class of medications, really this is a good way to end the semester because it is a review basically of all the disorders that we've been talking about more or less. Only we're looking at it through the lens of a younger age population. I do want to say at the outset of this lecture that there are um, uh, a couple of really quality shortcut pieces of wisdom that every therapist needs to remember when it comes to children and how they express their symptoms. And what's interesting about this is that this is also true for the elderly. And that is when it comes to anxiety and depression, there is a tendency in children and in geriatric populations to somaticize illness. Now, what does it mean to somaticize? Well, to somaticize, as you might remember from an abnormal psychology class, is a derivative or a derivation of the root word soma, which is the Greek word for body. To somaticize means to take some psychological symptom of some sort and to have it expressed not in a psychological way, and usually not in a way that someone can identify or talk about in conversation, but it's usually expressed in the form of a bodily symptom that has no organic cause to it. So, very frequently you'll find children, and this is especially the case under the age of 12, around 13 or 12, they have a very difficult time using the words depression or anxiety. Now, they might talk about being afraid to go to school, and they might say that they're feeling down or feeling sad or feeling scared, but usually they will not use clinical terms, very precise terms like depression or a clinical depression or a severe anxiety. What is more likely to happen is that children, and to some extent adolescents, but mainly children, they're likely to report their symptoms in terms of aches and pains that are pretty vague. They might, for example, talk about having a stomach ache. They might have a headache. They might feel nauseous, or their stomach might feel tied up, like it's tied up in a knot, and they're afraid that they might throw up because of the overwhelming tension. And they might report feeling dizzy. They might report feeling overwhelmingly tired. Now, part of this could be true if they're getting to bed at a very late hour and they're staying up late at night because of their anxiety and worry. It could be that they're not actually falling asleep until very, very late at night. And so by the time they wake up in the morning to go to school, they might be very, very tired. That's certainly a possibility as well. But generally speaking, there's a strong trend for children and to some extent adolescents to somaticize their illness. I had a psychiatrist friend here in our local community say that in his 30 years of practicing as a child psychiatrist, he never once heard a child under the age of 12 say, "I'm suffering from depression." For some reason, those exact words seem to be pretty elusive for most children. Now, by the time they get into their adolescent years, the words, as their vocabularies expand, and as their ability to connect how they feel with specific word descriptions improves, then you're going to find that teenagers are better able to talk about their symptoms than children happen to be. Now, very interestingly, although we're not talking a lot about psychopharmacology among the elderly, it is important to note that there's a very strong trend for the elderly to do the exact same thing. The elderly tend to avoid talking about terms like clinical depression and anxiety, and instead they tend to, just like children, they tend to somaticize their symptoms. Um, their symptoms tend to be expressed in the form of various ailments, pain, aches, side effects, maybe to medication. This is what they're talking about, but the elderly will very rarely say they're suffering from clinical depression. What's more frequent is that they will point to actual experiences in their lives that are causing them great concern or sadness. The elderly are, for example, frequently found to be experiencing loss in their lives, transition in their lives, and so those are some pretty big issues for them as well. So that's just one overarching shortcut that I wanted you to be aware of, and that is, as long as you are treating children, especially young children, you'll very rarely hear them talk about their symptoms in very specific terms. Usually they'll talk about them in roundabout ways. And so that's one thing that's an important thing to be aware of. So getting on to this introductory slide here, slide number 2, there is a dilemma that is mentioned in this chapter that says most childhood disorders are responses to situational distress and should be treated non-medically. Now, this is a value that is expressed in lots of settings. I know certainly around the United States, and I would have to check to see if this is also a shared attitude in Lebanon. But the prevailing idea is that when it comes to treating children for their psychological or psychiatric disorders, a least invasive environment is preferred, meaning they should have as few therapy sessions as possible. The children should not be overwhelmed with the amount of treatment they're undergoing. That's not to say that therapy is not a helpful thing for children. It very frequently is, and some kids really enjoy therapy. They really enjoy going in and talking to a counselor. It can be a very wonderful experience. But the idea is that you want to reduce any stigma that could possibly exist for children because they may get teased, or they may feel that there's something really wrong with them, or something's really off about them if they, quote unquote, have to go see a therapist about something. So you could get a little bit of resistance there. So generally speaking, when it comes to treating children and adolescents, the least invasive possible environment for them is considered to be the best. So if you can provide adequate care for a child in 4 or 5 sessions, as opposed to 10 sessions, then choose 4 or 5 sessions, and then just have the kind of relationship with the child where they can come in for periodic checkups and make sure that they're doing okay. That's a very important thing. And that also assumes that you're doing good work when you actually see the child in question. A big part of therapy is getting children to be able to put their feelings into words. That's a very, very difficult task. They may feel like it's a waste of time. They may feel like it's not worth the effort or the struggle. They may feel like it's very boring. But once they're able to get their thoughts in and feelings into specific words, into very concrete words that they can either talk about or write down or express maybe through art or some other way, there tends to be a lot of relief for them. They tend to feel a lot better. And they might not be willing to admit it right away either. If you ask them, how do you feel? They might say things like, I feel kind of the same. I'm not feeling a lot better. But what you'll actually notice is that as time goes on, they tend to feel better when they're able to put their feelings into words. Now, what's very important about that is not that once they put their feelings into words, then they will have landed on the truth. No, in fact, it's often quite the opposite. Once you put your thoughts and feelings into words, you may discover that some of the things that you were thinking or feeling are actually false and don't represent who it is that you actually are or who it is that you actually want to be. So I want to propose to you that the greatest benefit of encouraging children and adolescents to put their thoughts and feelings into words is not so that the truth will come out, but so that they will be able to critique their own thoughts and feelings and be able to weigh them against their own experience. That's a very important thing, and that's a task that we all need to carry on into adulthood. So that's the first part of the dilemma, is that most childhood disorders are responses to situational distress. That is, problems that are happening in their lives, and therefore should be treated non-medically. However, we also know that many mental health disorders find their beginnings in childhood, either in the form of trauma or in the form of, say, a genetic inheritance that is beginning to be expressed in a child. And in fact, when children do meet diagnostic criteria for a mental illness, they often suffer tremendously. One of the most important things to remember is that when a person meets diagnostic criteria for a mental disorder, it is usually associated with some form of suffering, either for the patient in question or, as is the case often in personality disorders, suffering for the people who live with the patient and must have to endure their difficulties. So children are no exception. When children do meet diagnostic criteria for a mental disorder, they're often in the midst of a lot of suffering and a lot of anguish. It can be very, very tough to suffer from mental illness in childhood. What's likely to show up on the radar screen for most parents right away are any kind of disorders that lead to social withdrawal and missed school. This seems to be especially troubling for kids, and it seems to be the first thing that's noticed by parents. So when parents begin to notice that their child doesn't want to go to school anymore, does not want to participate in activities anymore, if their grades begin to decline, parents are very good at freaking out about declines in grades or school refusal and things like this. What's also interesting is that teachers very much notice this kind of thing happening as well. There's a kind of false belief that children have that when they're struggling, that they are the only ones in the world who notice that they're struggling, and they often suffer under the false belief that they are suffering alone and no one can tell that they're suffering. In fact, teachers are very, very good at being able to detect when a child is not doing well. Teachers who have the benefit of being able to see a child several days a week and track their behavior over time, they often notice within a day or two that a child is not doing very well. And teachers are also very good at identifying who the best and brightest students in their classes are. And so when there's a student that's getting really good grades, and then that student suddenly begins to not get very good grades, teachers notice that very much. After all, teachers are not only tasked with teaching children, they're tasked with developing children. And so when a child begins to go in the opposite direction of where the teacher is hoping he or she will go, that definitely gets their attention. So it's true that parents should be noticing other things besides school, right? There are things that are more important for a child than his or her school performance. And yet that's one of the first things that parents pay attention to because, of course, most parents put a huge emphasis on a child's education, sometimes too much, as we all know. Okay, moving on to slide number 3. Preston, the author of your text, talks about this so-called kindling effect that begins in childhood, and he lists several disorders in association with this kindling effect. Now, you may have heard of this term kindling before. It's a word that not a lot of people know in English as it associates with mental illness. Usually in English, when people hear the word kindling, they think of the material that you use to start a fire, to ignite a fire, something that burns very quickly, like paper or pine needles or things like this, or leaves, dry leaves, that this kind of stuff burns very, very quickly, and it's one of the best ways to light the other parts of the fire that take longer to ignite. And so kindling has to do with getting the conditions ready and necessary for a disorder to develop. So the disorders listed here are bipolar disorder, ADHD, schizophrenia, some forms of depression and post-traumatic stress disorder, and I linked an article here about the kindling hypothesis and whether or not it is relevant in psychiatry. You're welcome to check that out if you want. The kindling effect suggests that disorders get progressively worse if they go untreated and may get better, or they might be prevented altogether if they are treated early. So I'm going to mention these disorders again: bipolar disorder, ADHD, schizophrenia, some forms of depression, and PTSD. So the idea here is that in childhood, if you can do an early intervention, the thought is that these disorders can be reversed and even prevented if the early intervention works. Now, this list is not exhaustive. There is a lot of evidence that suggests that early intervention for other disorders as well can be very effective, most notably in autism. That's very important as well. But these disorders are more frequently observed in childhood than autism, and so they've received a lot of attention. It's important, too, that if you're going to do therapy for a child, you need to go through the informed consent process. This is very difficult because oftentimes parents are willing, sometimes, to have the child go through counseling, but oftentimes the child does not want to talk to anybody, in particular a stranger. Now, you might think, well, if I have the parents introduce the child to me, the therapist, that might make it easier. But you also have to remember that sometimes the parent and the child are not getting along very well, and so the child might sometimes think that the parents suggesting that a child might need therapy, that this could be a source of great conflict within the family. So it does take a lot of skill as a therapist to try to coach children into making therapy their own and not trying to make it some sort of an agenda that you have. It's really important to have buy-in both from the parents and from the child themselves. Um, One thing, of course, when you're doing therapy or treatment with children is that you need informed consent. And informed consent for the child under the age of 18 is not required. Now, what's interesting, though, is that it's still a good idea to get what's called assent, ASSENT. Assent is not quite the same thing as consent, but assent is basically saying that we have an agreement in place that we'll try this out for a second, and if you like it, then we'll continue. And if you don't, we're not going to make you continue. So, assent is a good way to build trust and rapport with a young client. Remember, most kids are not wanting to come in to see a therapist. They think on some level that if they have to go see a therapist, there's probably something wrong with them. All right, one of the most important things, perhaps the most important thing to know about children with psychopharmacology has to do with drug metabolism. We have to remember that hepatic liver metabolism in children is very, very high. Thus, dosage rates for children are often as high as they are for adults, and sometimes even higher depending on the drug. Remember, we talked about this early on in the course, that because children often metabolize drugs so quickly, they often are prescribed drugs at very high dosage levels, which can be very surprising for parents because they see these dosage levels, and in some cases, they might be on the same medication and the child is taking a higher dosage than even the parent is. And you're thinking, well, wait a minute, why are they doing that? Especially when it comes to other medications like Tylenol or something like this, you're supposed to give children a much lower dosage. Well, remember, metabolic rates vary across age and across type of medication. So you'll sometimes see those differences. What ends up happening at puberty is, this may surprise you, it could be the opposite of what might be intuitive, but at puberty, the metabolism in a child slows down, and more side effects may present themselves that weren't there before. Meaning, don't assume that drugs that worked the same way before will always work in the same way. It's very important that if a child, in the event that that child is taking a medication during childhood, if they take that medication before they go through puberty, that they get reevaluated and get rechecked in terms of medication evaluation to make sure the medication is still being processed enough. You don't want to have higher toxicity levels building up in a child simply because their metabolism has slowed down. So that's an important piece. One other big problem when it comes to giving medication to children is that there just is not a huge body of literature that exists on medication for children. Besides the ADHD trials, which there are very many of them, there are very few good studies that exist on the effectiveness of treating children with medication. By the way, while we are talking about the subject of ADHD, it is absolutely essential that a child on ADHD gets good, effective treatment and therapy and gets on medication. The reason why is that this is a subject that not a lot of people like to talk about. It remains very controversial because we don't want to stigmatize, but the prospects for good adjustment later in life for a child with ADHD are very poor. In fact, it's often linked with very big behavior problems in later adolescence and chronic difficulties adjusting to life in adulthood. Again, because ADHD is a condition that seems to be frequently diagnosed, and at least in the United States, the idea is that it's overly treated with medication. We typically don't like to talk about this subject, and we tend to avoid it. But ADHD has been linked to a host of problems in adulthood pertaining to relationships, conduct, behavior, and just overall adjustment to life. So when a child has ADHD, it's really, really important that they get treatment for it because the prospects down the road tend to be not quite so good if it remains untreated. So that also goes back to the kindling effect. It's really important for early intervention when it comes to ADHD. Okay, so this lack of research is a major problem as we're talking about here on slide number 5. One of the reasons why is because it's not just the case that most of the studies have been done on ADHD and not a lot of other ones have been done, but because children are so young, they're usually too young to qualify for most studies. And a lot of ethicists believe that it's not ethical to do a lot of medication trials on children because they can't quite fully consent for themselves. So in order for a child to participate in a drug study, you would need to have a parent do the consent for them, and that prevents the child from fully being able to accept responsibility. So a lot of the drugs we just don't know, and a lot of the studies that are being done not on children who are participating in drug trials, but children who are being treated with medications, and then you're just looking at how those medications compare across children over time. So it's much tougher getting good data when it comes to the treatment of children and psychiatric medication. Now, the Food and Drug Administration in the United States is incentivizing more studies by drug companies to be done on children, but this also raises further the question of what kinds of studies are being done and are these entirely safe? Um, of course, the drug companies have a vested interest in making sure that new medications are being developed for children, because if it can be found that these medications can help, we know that there's a huge market for this, and parents will pay a lot of money to make sure that their kids are getting the right medication, especially if they've been found to be not harmful. So there's a little bit of economics at work here when it comes to the pharmaceutical companies and the development of these studies. So let's pay attention to what happens, but let's also be very skeptical and wary of the results that they come up with. We also have to remember that a lot of these studies are not completely independent, so they need to be um, studies that have been divorced from any kind of advantage to be gained or financial advantage to be gained. They can't be linked to the drug companies financially. Aside from case studies, very little research exists on severely ill children as well, because again, if you're going to do a medication trial, you need to be able to do a placebo drug, and there are all sorts of questions about the ethics of using a placebo drug on even adult clients, let alone child patients or subjects. So in general, what we're noticing is that drug companies are placing a lot of pressure. Or there's a lot of pressure being placed on the drug companies by their shareholders to develop new markets and new drugs for children. But this has become a real cause for concern among pediatricians and among parents who are skeptical of over-medicating their children. So again, the environment still seems to be, despite the fact that the FDA is wanting more good data, the general consensus is that using the path of least resistance is the one that's most important for children. The least invasive environment for children is the best one. Giving drugs to children also raises the question of their addiction potential. So we do know that some drugs that are given to children, such as Ritalin and other stimulants to treat ADHD, can be addictive, and their abuse among children who do not meet diagnostic criteria for a disorder has been noted. There are lots of stimulant drugs available illegally, and they can be purchased very easily at a lot of schools for children who don't have ADHD to take them just because they're thought to give a little bit of a buzz and make a child feel like they're a little bit numbed. And even if they don't have major focus problems, that it can help them focus a little bit more than they have been able to. So this has also been a concern that has been raised. But what's interesting, though, is that when you take a stimulant drug such as Ritalin, and you're taking it kind of not because of a prescription or that because you've been diagnosed, but you're just taking it off label, studies suggest that it actually produces mild dysphoria, not euphoria, and therefore it actually could reduce the risk of abuse of other drugs. So that's very interesting, is that when kids start to get addicted to Ritalin and they're interviewed, they're actually finding that the kids aren't enjoying taking it all that much. Now, their body may still crave it a little bit, kind of like other stimulants can be addictive, but the overall net benefit seems to be not that great. So, and some people have even argued that it could be a good warning sign to children against becoming addicted to a certain drug, because once you've entered that addictive phase, the pleasure of taking the drug has often worn off by that time. But this is not necessarily the case for the kids who don't have ADHD. For them, the feelings of euphoria seem to be a little bit more strong, even though numbness seems to be the most common symptom. We do know that benzodiazepine drugs are addictive. We've talked about those drugs before, and generally these are not advised at all to be given to children when it comes to the treatment of anxiety. In terms of ADHD, 5 to 7% of children in the United States have been diagnosed with ADHD. We're assuming that a lot of these numbers would hold true around the world. Um, we do know that children who have been diagnosed with ADHD tend to struggle with feelings of impulsivity and inattention well into adulthood. And although the motor restlessness does tend to lessen with age, 2/3 of patients will still have these kinds of restlessness symptoms into adulthood, usually just not as strong. Uh, one thing that usually will happen is that in younger childhood, when there's a child who has ADHD, they'll talk about kids who are unable to sit still. One of the most frequent symptoms that's noted is kids will be unable to sit still in their chair for a long period of time. Now, in adulthood, adults may be more able to sit still at their desk or sit still in their car or sit still in class. But what may happen instead is they become much more mentally restless and their mind might begin to wander a little bit. So that is something that tends to shift from childhood into adulthood. It's a little bit different. Um, but nevertheless, those symptoms do tend to persist well into adulthood. Many and most childhood disorders involve some degree of restlessness. So I underline this as a way of warning you against the overdiagnosis of ADHD. Remember, depression can result in restlessness. Anxiety can result in restlessness. Eating a diet that is too heavy in carbohydrates can result in restlessness. So just be careful that you're doing your due diligence and making sure that you've done a thorough review of the symptoms before making a diagnosis of ADHD. But remember, it's really important that you do the work in terms of diagnosing, because if a child does have ADHD, it's really important that he or she get treatment. You'll, of course, want to consider family history, history of symptom onset, and situations in which it manifests. Remember, this is just a reminder from your psychopathology class, that in order to be diagnosed with ADHD, a child needs to be exhibiting symptoms across two distinct settings. Usually that means they need to be suffering from symptoms at home, and they usually need to be suffering from symptoms at school. If you're only having symptoms in one setting, that usually means that it's less about the child and more about the stimulation in the environment. But when you start seeing that a child is suffering from certain symptoms, regardless of where the child is going, it's okay that there are some fluctuations, but typically when a child has ADHD, they're going to be having those symptoms show up across multiple settings. At least two are required for diagnosis. It is not enough to diagnose a child with ADHD when they're only showing symptoms at school. That's very important, or at home. It has to be more than one. All right, ADHD is often first observed as young as in infancy and in preschool, where behavior problems with other children are core features. That's a misprint there. It says with others children. It should say with other children. So one of the early symptoms of ADHD is difficulty getting along with other children. There might be some kids that other kids just increasingly find themselves complaining about. Other kids say that kid's mean, that other kid butts in line, that other kid pushes and shoves, that kid doesn't wait his turn, that kid blurts out answers, that kid doesn't seem to be very kind to other kids, he's too aggressive, he's too forceful, that kid doesn't know how to control himself. And so one of the early things you're looking for with ADHD is difficulty getting along with other children. Now, the symptoms do lessen when a child is in an inherently active activity. So that same child, if that child is playing a sport, you're going to find that that behavior, that troublesome behavior, doesn't occur as much. But when they're in an environment when everyone else is expected to behave and sit still and listen and cooperate, even for a short period of time, they often find that kids with ADHD really start to misbehave and not get along with other kids. Other kids in the class may find that a kid with ADHD is maybe a little bit annoying or not very popular. And not that they don't have charisma or they don't have intelligence, it's just that they are often getting into trouble and they can't control themselves. In adolescence, you really want to start looking for ADHD in the form of messy rooms. So a child with a very messy room is an increased risk for ADHD. Messy lockers, that's a dead giveaway when a child just can't seem to keep their locker room under control, when there's a lot of old food, lots of wrappers, lots of old, dirty clothes, and they just have trouble staying on top of their own possessions, and they can't take care of their own possessions. That's a major red flag for ADHD. A failure to work independently or having poor self-control. Another one is an overwhelming desire to touch things. Kids with ADHD often cannot walk down a hallway without touching the hallway, touching the pictures on the hallway, throughout the hallway. They seem to be very preoccupied with textures, with smells, with wondering how things touch or feel, and they have a very difficult time controlling their impulse to reach out and touch things. There's nothing wrong with being curious, obviously, nothing wrong with reaching out and trying to discover what the world is made up of. But when that happens a little bit too much, that's usually a red flag for ADHD. ADHD has been associated with frontal lobe dysfunction. That's key for you to understand because remember, the frontal lobes are the location in the brain where our primary impulses are restrained, where we can control and inhibit our primary impulses and engage in the behaviors that we would like to engage in that are more socially appropriate. It has also been linked to impaired dopamine systems. That should not be a surprise to you because when you think of the neurotransmitter dopamine, DA, that is associated with movement and controlled, coordinated movements. And so a child who has impaired dopaminergic systems could reasonably be expected to have difficulty in the area of reinforcement, reward, and movement. Dopamine stimulant drugs, such as Ritalin, tend to not only treat some of the symptoms, but one of the reasons why for this kindling effect and the reason why it's important to do early intervention with ADHD is that it has been found that kids who do take these stimulant drugs tend to be a little bit more well positioned to have healthy brain development. So it's another reason why it's really important for kids with ADHD to get treatment. A lot of them are not going to want treatment. Many of them are not going to agree with it. Many of them are going to think it's a waste of time. Many might not like the side effects of the medication, but it's really, really important that you get them on these medications because the long-term effects, again, for ADHD are not promising. And there's another article here that has to do with, if you're at all interested, with the link between dopamine and treatment of ADHD. ADHD drugs tend to be very effective. There's about a 70% success rate when it comes to symptoms of ADHD and their remission. But it may take some trial and error. So getting on, a lot of kids will try an ADHD medication and say, I hate it, I never want to try it again. But what really needs to happen is that you need to find the right dosage level. Because what most likely has happened is that you probably found the right drug, but what it has not happened yet is you've not found the right balance yet for you. So a lot of kids and even a lot of parents are ready to give up after one or two trials. They say, we tried the drug, it didn't work, we're ready to move on to something else. But in reality, you need to be a lot more patient with the medications because the drug, there is a drug out there that can help. It's just a matter of finding the right one and at the right dosage level. When you take an ADHD drug, especially ones that are not extended release, what you'll notice is that the effect of the drug is usually best in the early morning to noon time of day. And then once you get into the afternoon and late afternoon and the early evening, the effectiveness of the drug tends to wear off. So a child, once they come home, may actually start to become a little bit more symptomatic again. That doesn't necessarily mean that you want to take a drug in the afternoon or the evening. It may mean that you want to have an extended release drug, or it may mean that you need to control the afternoon and evening environment a little bit more. Most parents think that it's most important for children, if they're going to take a drug, that they take it in the morning so that it will help them while they're at school. It is also a concern that if you take an ADHD drug later in the day, it's going to keep them up at night and not have them able to sleep. So that's an important one too. ADHD drugs do tend to be needed as the child ages and as they proceed into adulthood. So as children develop into adolescence and then adults, they will usually need to remain on their medications. It's very important that they do, not only to help manage the symptoms and the behaviors and to help out in terms of the relationships, but for healthy brain development as well. It's usually best for kids with ADHD to start out with short-acting stimulants and then switch over to extended release drugs a little bit later as they're able to tolerate them. With depression, severe depressions in childhood can often herald severe depression and bipolar disorder in adulthood. So again, The general rule of thumb is that the more severe depression your parents tended to suffer from, the more likely you are to suffer from severe depression. And the more severe depression you suffered from as a child, the more likely you're going to suffer from severe depression and maybe even another mood disorder such as bipolar disorder later in adulthood. You definitely want to, when you're doing a diagnosis, this is important for children as well as adults, that when you're looking at depression, you want to rule out bipolar disorder, because if you get a person onto an antidepressant when they've been diagnosed with depression, when in fact they have bipolar disorder, the antidepressant can actually, the serotonin can cause a quick shift over into a manic episode. So that's an important one as well. For a lot of kids are not going to report necessarily feeling sad all the time, but they may talk about not enjoying life as much as they used to. So the term for this, anhedonia, an meaning without, and hedonia meaning, it's the same word we use for hedonistic or hedonism, just refers to pleasure. So anhedonia is a good psychiatric term that means a loss of pleasure, a loss of feeling of enjoyment, doing activities that normally bring happiness, joy, or pleasure. So with anhedonia, sex may not be as enjoyable as it used to be. Food doesn't taste as good as it used to be. It's a really good psychiatric term. And for children, it's going to result in them feeling like they're not as well connected to the activities that at one time gave them a lot of joy and happiness. Now they're just feeling like they're not necessarily sad, but just that they're not as easily made happy as they used to be. Another one that's really big is irritability. Irritability is one of the first warning signs that a child is not sleeping well enough, is not eating healthfully enough, or is suffering from a mental illness, or is abusing drugs. Irritability is a very important one. So it's one thing for children and parents to start getting into some arguments, not get along very well. But when you start getting into the drug abused child, the mental illness child, the sleepless child, or the malnourished child, irritability can be a big part of that. As we said earlier, vague somatic complaints are very frequent in children. Headaches, stomach aches, nausea, dizziness, overwhelming fatigue. These are all very, very commonly reported in children and in adolescents, but especially in younger children. A tummy ache for them might not necessarily be an acid problem. It might be that their stomach is kind of churning and in knots because of their tension. So there could be some gastric juices flowing that can cause some pain. But for a lot of it, it rarely has anything to do with indigestion or something like that. It has much more to do with anxiety. Children are usually not good candidates for taking tricyclic antidepressants, despite some studies that suggested early on that there could be some promising results. It shows that SSRIs tend to be much more effective than tricyclics and placebos for children who indeed have been diagnosed with depression. No studies exist on the long-term effectiveness of drugs. That's one thing to be on the lookout for. And this is a very important thing that's needed because with depression, relapse is so common. So we do need these studies, and we just don't have enough data on this as of yet. But we do need more studies that show what are the long-term consequences for being on an antidepressant drug for a long time. Children typically take longer to respond to antidepressant medications. Most adults will respond after anywhere from 10 days to a month, whereas children taking an antidepressant may not start to see a response for 2 or 3 months, 8 to 12 weeks. So that's a very important thing to make a mental note of. Dosages are typically started at the lower level because of abnormal metabolism of antidepressants, which can cause excessive buildup and some severe side effects. So in some medications, children take drugs at a higher level, but with antidepressants in children, they're usually started out at a lower level. There have been some studies that seemed to point to the possibility that taking an antidepressant medication could lead to suicidality in some children or adolescents, and that led to some drugs having what's called a black box warning label, meaning that this drug has been labeled as a drug that could potentially cause increased suicidal behavior. An example for this is the acne medication Accutane, which has a black box warning because it has been linked to potentially some suicidal behavior in some children and adolescents. Not very common, but it has been reported to be found. And the most famous set of studies that came from this at the beginning were this Paxil suicide studies. If you look at them closely, that actually yielded no suicides, despite the fact that children who were taking Paxil said they felt a slight significant increase. I'm sorry, not a slight significant, a statistically significant increase in what's called suicidality. So in this case, suicidality does not mean that you're actively that you're committing suicide, but that maybe you are thinking about it a little bit more. Now, one of the reasons why this could be happening is because several people have noticed that some suicidal behavior tends to be most apparent after a person has started to feel better after an extended season of being depressed. So that needs to be teased out as well. By and large, my opinion, officially, for you as a class, is that the benefits of taking an antidepressant for people who have been diagnosed with depression outweigh the consequences, or outweigh, not the consequences, but outweigh the drawbacks from potentially taking a medication. So obviously you want to monitor any child or any adolescent or adult for that matter who's taking an antidepressant medication and make sure that there's not an increase in suicidal behavior. But for the most part, we can expect people to get better. They tend to be very effective. That is, again, when a person has actually been diagnosed correctly with depression. The Paxil suicide studies, as I note here at the bottom, was a study of 1,300 patients taking Paxil, and suicidality was reported in 1.2% of the placebo patients, that is, among the patients who weren't taking any medication at all, but 3.4% of the Paxil takers, which is may not sound like a big leap, but that is going up 2.2 percentage points. And many of these feelings of suicidality actually happened after they discontinued taking the medication. So that's another thing as well, as it could be that they were having a therapeutic benefit from taking Paxil, but it was the discontinuation of taking the Paxil that may have actually caused the feelings of suicidality. So bottom line, we need to do more research on this area because we simply do not know enough. Going on to slide number 12 and talking about bipolar disorder. Very interesting that in childhood bipolar disorder, 70% of childhood onset cases start with depression and not with mania. So that's why it's really important, once again, to do a diagnostic rule out of mania and bipolar disorder when you see a child who's been diagnosed with depression. You also want to rule out ADHD, again, because with ADHD, you have some cognitive symptoms that overlap with some of the cognitive symptoms of depression, especially in the area of a lack of focus and lack of concentration. So in children, they do tend to be a little bit more prone to rapid cycling, so that's something that tends to decrease with age. You also want to look for intense rage and oppositional behavior. Now, some parents will say that their children, when they're not feeling very well, can become incredibly angry. Now, with bipolar disorder, we're talking about an anger episode that lasts not like 5 minutes or 10 minutes, but in some cases, extended rages that can last 2 to 4 hours per episode. That's a really, really big problem. This is a very controversial disorder for children because there's been a surge in childhood bipolar disorder diagnoses. Now, one thing I want to mention is that right now the current trend in bipolar disorder is to go down. It's going down. The number of children being diagnosed with bipolar disorder, we seem to be experiencing a kind of a backlash where for a few years this disorder was surging and going way up, and now it seems that there's been an overdiagnosis and people have not been paying attention to the diagnostic categories. So there have been a lot of false positives in recent years. Currently, ketamine is used to treat kids with a subtype of bipolar called fear of harm. A fear of harm, this is a paper that was developed by Dimitri Papalos at the Albert Einstein College of Medicine in New York. And this has to do more with some of the extraordinary fears that kids with bipolar disorder have, that harm will befall them or that they will cause harm. As it is in adulthood, medical treatment of bipolar disorder is very tricky. When a person is feeling depressed, usually a combination of antidepressants with mood stabilizers are used, and you very rarely are going to use an antidepressant alone, even in treating this with children. With mania, usually you're going to use a combination of second generation antipsychotics and then mood stabilizers. So, antipsychotics, notice that's not only trickling into the treatment of bipolar disorder in adults, but in children as well. And in the last slide here, we're talking about anxiety disorders. Again, the use of psychotropic medications to treat anxiety disorders should be weighed very carefully. In another slide earlier today, we talked about how the benzodiazepine drugs are usually not very effective for children, and they, of course, tend to be very addictive, so we need to be careful there. In general, therapy for anxiety disorders tends to be more effective than medication. So remember, with anxiety disorders, with most anxiety disorders, the treatment of choice in children is a form of cognitive behavior therapy that combines a lot of the cognitive interventions along with exposure and response prevention, ERP, exposure and response prevention, where you are exposing children to some degree to the thing that they're afraid of, but then preventing them from engaging in the anxiety associated response. For different subsets of anxiety disorders, such as OCD, which we've already put into a separate category in this class, SSRIs are warranted in children, as well as with PTSD, separation anxiety disorder, generalized anxiety disorder, and social anxiety and phobia. Just keeping in mind that the first two are the ones that are the most associated with medication and SSRIs. If you are going to use SSRIs and if the anxiety is severe enough, then it's okay to use with GID and social anxiety. But remember, with kids as well as with adults, therapy tends to work better than medication.